Hello everyone, my name is Dr. Srilakshmi KJ and currently I'm a junior resident at a tertiary care hospital and a research student at the California Institute of Research and Technology. Today, I'll be presenting a case report titled Goldenhar Syndrome, an atypical presentation with developmental delay, guided by my mentor, Dr. Wakas Bani. Goldenhar syndrome is a rare congenital disorder that affects the development of the craniofacial region, the spine, and the ears. It is characterized by a wide range of symptoms that can vary in severity and may include facial asymmetry, microtia, or even anosia, along with cleft palate, cleft lip, and vertebral abnormalities, and even some eye abnormalities. The cause of Goldenhar syndrome is not fully understood, and it is thought to be related to the disruptions in the early embryonic development of the affected tissues. The diagnosis is typically made based on physical examination and imaging studies. The management involves a multidisciplinary team of healthcare professionals, including geneticists, audiologists, and plastic surgeons, along with pediatricians. It is also called as an oculo-auriculovertebral syndrome, OAV, or a hemifacial hypoplasia syndrome. It is a disorder which is sporadic in origin, and the birth defect has an incidence of 1 in 3,500 to 1 in 5,600 live birth, with a female to male ratio of 3:2. Goldenhar syndrome was first observed and recorded by Carl Fernand von Alt and Maurice Goldenhar, who were the first scientists to describe the syndrome in detail, and hence this is called as the Goldenhar syndrome. Going into the case presentation, it is a case of an 8-year-old female child who was diagnosed with Goldenhar syndrome at the time of birth. She presented with upper eyelid coloboma with left eye larger than the right eye, bilateral limbal dermoids and lipodermoids, along with preauricular skin tags. She also had incomplete eye closure and visible glow of both the eyes. A lack of an upper eyelid was associated with the exposure of the eye to a variety of environmental stresses, which is why the child was advised to undergo a corrective surgery at 3 months of age. So the child underwent the corrective surgery under general anesthesia, which involved bilateral upper lid coloboma repair with eyelid reconstruction, and while using the excised preauricular skin tags for reconstruction of the eyelids. The current presentation of the child involves no typical features of Goldenhar syndrome, such as unilateral asymmetric facial defects, or ear defects, or mandibular defects, or even vertebral and abnormalities. It was found that patient in her later course of development showed delay in milestones as well as delay in development of her speech. She has a delay in development of social cues as well. The patient at the age of 3 months also showed episodes of seizure, which led the parents to perform an EEG. The child's parents was also advised to perform an MRI to identify the exact cause of the delay in development to identify a delay in the development of milestones. The child was diagnosed with seizure disorders and was prescribed anti-epileptic medications. The MRI performed showed focal area of thinning of the posterior part of the corpus callosum. The global developmental delay with severe presentation in the form of speech delay was attributed later on due to the thinning observed in the posterior part of the corpus callosum of the brain. Currently, the patient displays various behavioral tantrums and mood changes. She often finds it difficult to sit in a group of class with her own peers and needs help with basic toilet training and feeding. Presently, the child is given treatment. She started on Levipil at the age of 3 and shows a gradual decrease in episodes of seizures. She is also given language and speech therapy along with occupational therapy for improvement in fine motor skills. Going into the discussion of this topic, it is advised that parents as well as pediatricians and doctors who are first in contact with the children are supposed to look for facial and structural abnormalities. Some children with severe facial abnormalities and cleft palate and spinal deformities have a earlier diagnosis. Hence, they can be given treatment in the form of surgical corrections at a very young age. This can significantly improve the quality of life of the patient. Such syndromes have a very low presentation, like as mentioned before, which is 1 in 3,000 to 1 in 5,600. Hence, a key lookout has to be kept for such specific features. Also, the fact that this syndrome is diagnosed mainly based on clinical findings and presentations of the child, and not via enzyme testing or any proper diagnostic testing methods have not been yet discovered. Such syndromes require special attention by the pediatric doctors as well as the primary care physician of the child. I hope that this case report brought an insight to each and everyone who had listened to this presentation. And I would take this opportunity to thank California Institute to provide such a wonderful platform for doctors like us to present this case. And I would also like to thank my mentor, Dr. Wakas Bani, for his time and advices in the development of this poster. Thank you so much.